I'm just one, so every surgeon does things differently. And so I'm just one surgeon from the US, and even though it says US experience, this is just really my personal approach to lipedema reduction surgery.
Hi everyone, I want to explain my approach to lipedema reduction surgery. And I call it lipedema reduction surgery and not liposuction. In the US, liposuction is only coded as a cosmetic procedure, and so I want to make the distinction that this is a reconstructive or improving function surgery, and so I prefer calling it lipedema reduction surgery. I divide it in 6 parts: mapping the venous and lymphatic structures, marking the surgical area, administering tumescence, suction, aspiration, manual extraction of fibrous lipedema nodules, and then dotting of compression. So we map the venous and lymphatic structures with a high frequency ultrasound, looking for the saphenous and small saphenous, and then the lymphatic structures are going to lie medial or lateral to that they run the course. I'll show you that in another slide. Why do we do this? Dr. Herbst and I have reported on a series of lymphatic injuries that occur after liposuction with lipedema. This is a case that we reported on a lady with lipedema who underwent liposuction and developed lymphedema in her right lower leg. This is the lymphocitogram that we ordered, and we don't know the rate of this that occurred. It's rare, probably, but when it does occur, it's devastating. So I feel better taking these precautionary measures, mapping, and taking extra care in those areas where the lymphatics run. These lymphatics have been well mapped. This is Shinikoa's mapping. We also sometimes do ICG mapping as well. But as you can see, the principal lymphatics run in the leg close to, sometimes in, and then parallel to the greater and small saphenous in the front and back, as you can see here. We mark and prep the patient. We do give oral sedation when with 2 milligrams of lorazepam and 2 milligrams of oral Dilaudid, and then use Betadine chlorine prep solution to sterilize them. I use tumescent anesthesia. I was trained by Dr. Klein. I follow my mentor and still use his techniques. I use his pumps and Monty tip cannulas. I believe in generous tumescence, and feel like that is also protective of lymphatics. I use a micro-air liposculptor for suctioning with a 3 millimeter multi-hole cannula. I occasionally will use a double Mercedes 4 millimeter for on my larger patients, but that's usually. So some patients we do the legs in 3 surgeries. Some we do it in 2. So smaller patients we were able to divide and do the legs in just 2 surgeries. The lateral, outer, the way most surgeons in Europe do, and then the inner as the second. But for our larger ledgers, we divide it into 3, and these are large volume liposuctions. The average volume is around is over 5 liters removed, and then we do pair them with the So, for example, the lateral thigh is weakened with the buttocks when we do that way. So after we have done our suction, we feel for fibrous lipedema nodules, and those that remain we sort of milk along the long axis and loosen them up, and then either remove them through the adducts, or we have to make another incision to get the lipedema nodules out. And then after the surgery, the patients walk on their own power to use the bathroom, and then we put them in compression. So we leave the adducts open, and then wear medical grade compression. Then we follow them up either the next day or 2 days later. Well, so now I'm gonna get into the actual video of the surgery. Thank you for your time. I'm gonna and we're gonna show you the actual surgery.
So before surgery, we mark the venous and lymphatic structures in the leg. I've made just scanned and made some blue dots for where the saphenous, the greater saphenous runs along there. Now the lymphatics channels that have been well described, and they run parallel to the greater saphenous and the smaller saphenous. And so we first, with high frequency ultrasound, we map the saphenous, and then we find the major or principal lymphatic collectors. And so here, if you can, here, right there, that's the saphenous structure. Then I go long on that, and there's actually just to the side of it, there is a little lymphatic channel, and I'm marking that in. So that's going to be marked in green, and then the saphenous right here is going to be marked in blue. So I scan this to show these landmarks, so that we can take extra care in these sections to not transect. But I will also mark the saphenous up here, because we are going to be going up into the thigh.
You can fast forward through here.
Your medial lymphatic collecting duct, and we're marking the saphenous, the small saphenous, because we're working in the calves and ankles, as well as the lower part of the thigh. So now we're going to go. We see here the saphenous sheath, and if you can see right here, there's a lymphatic that's in the saphenous sheath here, and you can see the lumen of it. And if you look very closely, so you can, and when we do horses, we can sometimes see flow in these lymphatics, and that's how we're sure it's a lymphatic and not another structure. We're on the other leg now, and we can see here with the small saphenous sheath, and again there's a small lymphatic running in there, just medial to the small saphenous. So now we have the boundaries on the back of the leg, where we see a principal collecting duct on the lateral and medial to the small saphenous, and that's sort of watershed area where I take extra care on the back of the leg. So we have a beautiful lymphatic channel here, marked going longitudinally, and my expert sonographer Crystal has come through again today.
You can fast forward, please.
So it's
Dive here.
yeah, so it's areas. Go down the ankle. This little fat lobule on the ankle.
Fast forward, please.
So we're gonna, we just have it going here, and there, and we're gonna get this down. That's, our markings are complete. So I'm starting with just making some adits. We use punch biopsy to place the adits. And I'm just, I like to place my adits, my access points for the tumescent midway, lower boundaries and upper boundaries. So basically, and I'm just right now just a little punch hole. This is a 2 millimeter punch, and I put also some medial to it, and so I can basically stay parallel in these areas of concern. Add it out here laterally. Now the patient is a little orange, and then it turns.
So just tumescent here.
Completely swollen. That's So I'm raising a wheel right here, just, getting ready to do my adits. Here, we'll make sure it's good to nest.
So beginning the suctioning there.
So this is the micro air Lipo sculptor, and I want to thank Micro Air for supporting some of my research. So we use this to help break up the tissue, and we find that we're able to get a little more of the lipo from the tissue out with the liposculptor. As you can see, the cannula strokes are longitudinal. I'm following the marking of the lymphatics and staying clear of them, just going longitudinal up the leg and Get a nice smooth. We're right in the plane. The perfect plane for this is the easiest plane. It's not too deep, not too superficial. Just go smoothly through the subcutaneous tissue. You can see here now it just goes very, the vibration of the candle is doing most of the work here, and I'm just gently moving it around so that at a pretty steady pace so that we get even harvesting of the tissue. The lateral, there's a characteristic increase in the lateral cap here, that we tend to get extra thickness through here, and so I want to get that reduced. So I'm just going over the knee complex here now from the mid calf, and as you know, ladies with lipedema, they tend to have that hangs over the knees, and now she's again staying longitudinal as longitudinal to the collecting ducts. As you can see, I make a lot of additives, and I, like my mentor, Dr. Klein, I believe that, especially when you make these tiny additives that really heal with almost no scar, that the number of additives allows you to each time to extract the tissue with putting the minimal stress on the structures around it. So so I'm able to more evenly and completely extract the tissue because I have additives or access points at each angle. And then you're going to see we're going to do multiple positions. My watershed area of caution, but I still maintain the longitudinal orientation of the cannula, and just in the plane that's not too deep and not too superficial, just as easy like butter. On this power assisted handpiece is really doing most of the work. I'm just
moved and adjusted to 6 different positions.
This is a little different is that I have them
So that
turn
you can get
on their
each little
sides,
quadrant
and
of the
we
leg.
go through about
Single position.
6 different positions each patient as they go for the full 360 degrees. So that each side is up, the interior is up, and then the posterior is up, and then the laterals up, and then the anterior. So there's these.
So what you can see here, still the Yeah. Now we're on our side, but we're slightly turned towards the stomach. So, just get to this. One more little angle to get all the lipedema tissue I can.
Thank you. This is the manual extraction. This is a fibrous nodule left in there, and just sort of, as I said, milk it out, and then finally, before they get off the table, we milk all the excess tumescence and feel for, make sure there's a smoothness and evenness. And then the dawning of the compression. And then we just wrap with pads for the drainage, which is quite significant for the first couple days. The adits are left open to drain, and they do drain quite a bit, especially in the first 2 days.